Welcome back to our next lesson in point of care ultrasound here at Waco Family Medicine. In our last session, we talked about ultrasound physics, especially how sound interacts with tissue. We talked about attenuation and absorption and the scattering of waves and how all of those complex physics create the bioeffects and the considerations we need to have to practice ultrasound safely. And then lastly, we showed a couple examples of artifact and explained how the physics behind those can help us to determine what's actually going on in all of the tissues that we're ultrasounding. This lesson will go over some of the conventions of point of care ultrasound use. We'll talk about positioning our patients for exams and how we position and orient the probe so that we can obtain the images that we're looking for. We'll talk about the different machine settings and techniques that we can utilize to clearly see the intended structures of each exam. And we'll talk about the different ultrasound modes, what they represent, and how we recognize them. And then we'll end our time today talking briefly about the legal and logistic clinic environment that we have to utilize this technology and what necessary resources need to be in place for us to be able to document and bill correctly. Starting off with positioning, by convention, just like our physical exam, this ultrasound machine generally should be located on the patient's right side when possible, and we should be sitting or standing next to the machine and to the right side of the patient. When utilizing ultrasound, try, if you can, to rest your hand. I like to rest the side of my hand, like with my pinky finger, on the patient's body. That's going to help stabilize the probe and help your images be much more consistent. And then hold the probe with only 2 fingers. So for me, I hold the probe between my thumb and my index finger, with the rest of my fingers sort of splayed out and resting on the patient's body for stabilization. Whether you stand or sit is really up to you and the type of exam that you're performing, but the patient is usually going to be laying supine. Every now and then you may need to roll or raise them to a seated position as needed to get the images necessary. So now that you've positioned your patient, let's go ahead and put a probe on them. And we get a whole bunch of gray images and static. Well, there's probably some settings we need to go over to understand how to get a good ultrasound image. Getting a good ultrasound image comes down to a few things. We need to have the right probe. We need to know what modality and presets to use. We need to orient ourselves well to understand the anatomy, move the probe in the correct directions to be able to image the entirety of the organ that we're looking at, optimize our image using machine settings, and troubleshoot when things aren't going the way that we want. So let's dive into each of these in a little bit more detail. Probe selection all comes down to 2 things: frequency and footprint. Frequency refers to what frequency of sound we input into our patients, and that determines both our image resolution and the depth at which we can see. Meanwhile, footprint refers to the area that makes contact between the probe and the patient, and this determines how much real estate we get to see and what obstacles we might be running into or that we can avoid. Higher frequency ultrasound beams have better resolution, but this does come at the expense of depth penetration. Low frequency waves travel farther, but have less resolution. This is a key point that I want you to remember as we move forward. Footprint refers to the contact area between the probe and the body. So probes like our curvilinear probe, for example, that we use in OB, have a huge footprint, versus some small hockey stick probes may only make a couple of millimeters of square surface area in contact with our patients. This footprint matters because it both gives us broader or larger images if we're looking at a big organ or big structure, but it also takes up real estate that we might need for procedures such as paracenteses or lumbar punctures. And of course, there's anatomic considerations too. So if we're working in the chest wall, we have the ribs that we need to worry about. And so a big bulky probe like our curvilinear probe is going to have to interact with all of those ribs to be able to get an image. And so we'll have to consider that when choosing which particular transducer we want to use for an exam. Let's dive into what our imaging modalities are. These may be things you've heard of. I'm going to start off with the one that you're probably most familiar with. So when all of us think about ultrasound, we generally think about B mode or brightness mode. This is that standard 2D grayscale image that plots intensity at calculated depths. If those words don't make sense in that order for you, I'm going to have some graphics later on. But if you can just remember that the typical ultrasound that you think of as B mode, it can help you differentiate between some of the others. Now, if B mode is one dimension, or excuse me, 2 dimensions, it implies that there's also a mode in 1 dimension, and that's called A mode. You probably don't have much experience with this unless you worked with an ophthalmologist or some other specialty that uses these when you were in med school or at some other point in your life. But this is another thing that we'll talk about and that we see utilized from time to time. And then lastly, we use M mode quite a bit in family medicine, which stands for movement mode. M mode plots echogenicity along a single ultrasound beam and expresses that as a function of time. Lastly, we have our different Doppler modes. And while there's a whole bunch of different types of these, we'll go over the two that I want you to know in detail, power and color, at a later slide. Let's start our discussion of the different ultrasound modes with A mode or amplitude mode. Although this is not one that we use commonly, it is, I think, basic to understanding how we generate an image based on what we do to the body. So this will be a good example of the physics that we talked about in our last lesson. So let's pretend that this is an eyeball, and I've drawn a little schema of that out here. So this wiggly line on the far left, this represents our eyelid and the soft tissues of our eyelid. Here we have the front of our eye, our cornea, we have a lens here, vitreous, and then the back circle is the retina. While this isn't super too detailed anatomically, it serves as a pretty good representation. So if we look on the right, this side of the screen represents what an A mode output would look like if we were to send just one beam into the eye, which is what A mode does. And what we see here is that we get reflection peaks of different amplitudes, with the highest referring to the areas where there's the most impedance of the sound wave. So if we remember impedance is generated not only by the structures that the ultrasound wave is passing through, but it's generating echoes at each of those structures' boundaries. So we have the skin here, and there's all sorts of boundaries inside the skin and soft tissue, so we get lots of echoes here. And then those sound waves hit the cornea. And there's a big difference between the texture and density and the impedance values of the soft tissue and of the cornea. So we expect to see a strong echo signal. And sure enough, when we look over here on the right, that's what we see. Then we move into the anterior portion of the lens and the posterior portion of the lens, with both of those barriers also demonstrating really strong peaks. And then lastly, the echoes travel through the vitreous to the retina, where there's another change, and we see the retina peak back here. So echoes are being generated at each of these boundaries and result in an amplitude that we can see on A mode. Pretty simple, right? It follows the physics we talked about. B mode takes A mode, and instead of having just one beam, we have multiple. And so we get a whole imaging plane, a 2D image, that's black and white grayscale based on the strength of those echoes that are being generated. So we get echoes all along the barrier of the cornea, but we don't get as strong of echoes from the sclera over here. And so we see a bright white line here for the cornea, and then the sclera has a little bit of echogenicity, but not nearly as much. Same thing, we don't have any echoes within the vitreous because there's no boundary changes, but the second that all of those waves hit the retina, we get a strong signal with some posterior acoustic echogenicity, or some posterior echogenic enhancement. And I think that's one of those artifacts that we talked about as well. I think the best way to understand M mode is to look at it being generated as it's happening. So this is an example of a vessel, most likely the IVC, being compressed by the ultrasound transducer and more pressure being applied to the body. M mode is generated by taking one slice over and over and over again, and then laying those slides out next to each other as a function of time. So basically this shows us how one plane is moving over time. We use this to measure things like fetal heart rates, the heart valve motion, vessel compressibility, lung sliding, and lots of other applications. And where most people get confused is by thinking that this is trying to generate a 3D image. But no, just if you can remember, there's just one beam that's being sent into the body over and over and over again. And then with time, that's being plotted next to each other. We can see that this represents the same portion of tissue as this does, but that at this point in time, that plane of tissue is much closer to this plane, and that's because of that compression. So if this confuses you, I think once you start doing it in real life on a patient, you'll kind of start to intuitively understand it. Next, we have C-mode and 3D ultrasound. These aren't technically the same thing, but sometimes you will see them be used interchangeably. Let's talk first about C-mode. So C-mode is basically taking B-mode at a variety of different values. Basically, you're just taking one beam, and then you're taking B modes across that beam by changing the angle of the transducer to get a pseudo 3D image. Really not a lot of medical applications in point of care ultrasound right now, but if that changes in the future, we'll go into this in more detail. It just stacks all of them up to create an image. And the difference between that and, say, a 3D ultrasound is that in 3D ultrasound, the transducer in one position is sending out signals, waves or beams in different angles to generate a 3D image. All right, let's review what the Doppler effect is. So remind yourself that the frequency of sound that we emit from an ultrasound transducer is constant. However, we know that tissue inside the body is often not constant. Our blood cells are moving, our heart is beating inside our chest, our lung is sliding. And so those different movements affect the rate at which we experience frequencies being returned in the echoes that we measure. And those shifts can be measured and calculated to give us a velocity. And this is like that siren of the car that you hear when the ambulance is passing by and it goes, wee. It's the same sound being generated. The pitch is constant with that siren. But as the vehicle approaches you, the pitch seems like it's getting higher. And as it passes, that pitch seems to be getting lower. The same thing happens in ultrasound. Now, one of the complexities of physics is that we can know the velocity or the location of that signal with great accuracy, but not both. While this is not something that we commonly encounter in point-of-care ultrasound, if you get into some of the more advanced applications, more advanced cardiac or fetal ultrasound, you may need to know that velocity and location both independently can be measured with accuracy, but sometimes trying to get more of one will impede your ability to measure the other. Let's talk about color and power Doppler. So color Doppler uses superimposed color on the B-mode image to represent velocity. And it does so by having both a positive and negative scale, and with positive velocities being represented in one color and negative velocities being represented in the other color. And we'll have a whole slide dedicated to interpreting that here in just a second. The difference between that and power Doppler is that power Doppler is much more sensitive, meaning it can pick up lower flow, but it does not tell us the direction of flow. So both of these pictures, with each of them being labeled as either color or power, are both looking at, in theory, the same structure, not in the same patient, but the same area of the body, the femoral vessels. And in one, we can see that there's very clearly two vessels there, with one flow occurring in one direction and one flow occurring in the other direction. We see the same structures over on the power Doppler slide, but instead of seeing the colors be different, one blue, one red, what we see is a stronger intensity, those brighter yellows in one of the structures, and lower flow or less yellow, more reds, the other end of that spectrum, in the other vessel. You utilize color Doppler often during procedures, so like placing central lines, versus power Doppler, which we often utilize when looking for low volume flow in, say, knee injections or something like that. So here's a key slide. By convention, the ultrasound machine will always interpret flow away from the probe as being blue and flow heading towards the probe as being red. There's an acronym for this. You can remember either TRAB or BART. I like BART personally. And this is a key point. But it's important that we emphasize that color is not a reliable indicator of anatomy. You can always switch the scale on the machine so that it reflects opposite, or just by changing the angle of your probe, you'll get a switching of that color as well. So do not use it as an indicator of anatomy, only of flow. And if your settings are correct, then the BART acronym should be helpful to help you remember which direction that flow is facing. And I thought you might need a little bit of break. Clear your heads. Here's my baby boy. His name is Doppler, just like Doppler effect. All right, let's talk about putting the probe on the patient again. By convention, the probe should be oriented, meaning that the indicator should point towards the patient's head or the patient's right side. Now, there are a few exceptions to this. In cardiac ultrasound, which we'll talk about more in detail, if you're looking at an organ like the gallbladder that doesn't perfectly lie on axis, oftentimes you'll need to rotate the probe to get that in axis, but still in general, the indicator should be towards the right or towards the patient's head. For OB images, it really relies on the fetal anatomy, depending on what you're looking at. And then in intracavitary probes, since those probes are going actually inside the body, whether it's into the rectum, into the vagina, into the mouth or neck or whatever, those things, generally the convention is that the probe should be oriented up and to the patient's right, or anterior into the patient's right if the patient's in the normal prone position, or supine position. Making contact. So I don't know how many of you have seen this excellent movie. I mean that a little bit sarcastically, but it is one of my personal favorites for nostalgic reasons. But other than it being about sound and aliens and a little bit of sci-fi, there's really not much ultrasound application. However, I thought it would be a funny slide addition. Anyways, I used to have a mentor who told me, Ryan, the ultrasound should never be the first thing to touch the patient. And what she meant by that was that I should always be augmenting my physical exam with ultrasound. So before I put the ultrasound probe on a patient, if I'm going to look at their heart, I should listen to the heart. I should palpate and feel where the heart is and feel that point of maximal impulse before I place the transducer down. And while I'm guilty of not always doing that, every time that I'm having trouble with generating an image that I'm desiring, that's usually what I go back to. I hear her voice in my head saying, hey, that should not be the first thing to touch the patient. And so I'm going to encourage you all to do physical exams first and then extend your physical exam by adding on the ultrasound. Contact in this sense is referring to the transducer air-skin interface. And that means that, we've got this complex machine that's generating those mechanical vibrations that are causing sound waves, but we also have this gap between the transducer and the skin and the body. And so we need to overcome that in some way. And the way we do that is by applying a coupling medium or ultrasound gel. Now, every now and then we use other liquids too. I've seen someone use water. I've seen people use Surgilube. I've seen people use, Hibiclins, all kinds of stuff. But the best medium, if you have access to it, is ultrasound gel. One other saying that really stuck with me from my mentor was, apply it like toothpaste, not like ketchup. And what she meant by that was squirting out smooth lines of medium is much better than just sort of shaking up the bottle and squeezing it as fast as you can. And the reason for that is because you get little bubbles that get interspersed into a squirting liquid out of a tube like ketchup. And those air bubbles are going to interfere with your sound getting through. And so steady but gentle pressure, both from the gel tube and with the probe, can help displace those bubbles, have a smooth, clean transducer air-skin interface, and then help your contact allow the best transmission of sound waves. And you can't get out of not putting your hand on the patient. You will touch your patients in this curriculum. I will not allow you to hover because you'll slide all over the place and you won't get good images. So one of the hardest parts of teaching ultrasound is that when you have the probe in your hand, it's hard for me sometimes to give you directions on how to manipulate that probe in a way that optimizes your image. To help with this, I want to go over what we call the cardinal movements, which are instructions that I'm going to give you in terms of trying to move the probe in the direction that's helpful and get you a better image. Now, these words that are currently on the screen are not necessarily those cardinal movements, but they are a rhyme that I came up with a couple of my buddies when we were first learning ultrasound to help us remember how to optimize an image when we didn't have an attending or an upper level or a ultrasound fellow who was coaching us. And this rhyme is target, translate, isolate, rotate, interrogate. And we're going to go over how each of the movements can help you do that. What this overall means, this rhyme, is that targeting stands for thinking about the anatomy that you know or using your physical exam to try to find the organ or the area that you're looking at before you even place the ultrasound machine on the patient. And then once you do, you're going to slide the probe or translate it, and here's an animation of that, to the area to get that organ in view. So if you think you know the gallbladder's in the right upper quadrant and you put your ultrasound probe down and you don't quite see it, the first thing you're going to do is you're going to translate your probe superior, inferior, laterally, medially to try to isolate that organ. Isolation just refers to finally finding it and then getting it into the center of the screen, adjusting your depth and your focus so that you can get the best image possible. After you translate, then you rotate. So rotation refers to twisting the probe to get the organ in the right axis. So twisting here is going to be called rotation. So I'm going to say rotate your probe 90 degrees clockwise, or rotate counterclockwise until the organ is in long distance or long axis. And that will be the next step after translating. Next, we'll talk about waggle or towing. So I generally will say towing. Every now and then you'll hear someone say rock the probe. But for me, rocking the probe, if you rock it left to right or up and down, they both mean different things. So I try to say toe in or toe out. Or if I do, I say rock the probe to the right or rock the probe to the left. So this is how, once we've gotten our footprint situated over the right portion of the patient, we need to adjust the angle of insonation by adjusting the beam, almost like a flashlight. We've got it in the right spot, but we need to curve it around to look at all the different angles. I think, a good analogy for this is, imagine if you were doing some plumbing underneath a sink and that there wasn't great lighting in there. Targeting and translating, isolating, rotating, all of that is getting your flashlight into the spot that you need to be able to see and illuminate the cavity that you're working in the plumbing. And then waggle or towing, and our last movement, fanning, are you pointing that flashlight, now that it's in the right spot, to be able to illuminate all of the dark corners. The same thing. So this is called fanning. So you can also refer to this as rocking back and forth, but you'll hear me say fan the probe, and that just means kind of pushing the probe forwards and backwards without moving, without sliding, and just changing the angle of insonation to be able to illuminate all of a structure. So those are your cardinal motions. Image optimization refers to all of these steps that we've talked about, plus a few more, to make the best image possible. And if you look at this picture, you see a baby giving us the thumbs up, and you're like, wow, how could this image be optimized? And I tell you that as an Aggie, that's how you do it. Get going. So image optimization refers to optimizing the depth by making sure that we don't have a lot of extra wasted space at the bottom of the screen, deep to the structure we're interested in. But we're also deep enough that we can see all structures that we're looking for. Next, we're going to adjust the gain and the time gain compensation. So gain is like the volume. So gain refers to how bright the images are on the screen. And you can adjust this in two ways. First, there's an overall gain wheel. And by twisting that wheel to the right, you can turn up the gain on the entire screen, make the whole screen brighter. And the same thing, if you turn it to the left, it'll turn the whole screen darker. But every now and then there will be situations where you'll want to turn up only one portion of the screen. And that's called time gain compensation. And there's some sliders up on the left upper corner of the keyboard where you can do that. And we'll go over that in your skills check. Lastly, you can change the focus position and the focus number. And that helps you determine exactly where the highest resolution of your screen is. And of course, use your anatomy to guide you. And all of this stuff is kind of hard to explain without looking at a machine. So we're going to go over that in our next lesson for knobology. So you see a little preview there. So what if you're troubleshooting and you're not getting the greatest image? Well, first of all, don't panic, breathe. It's going to be okay. And then remember, have you augmented your exam? Have you already touched the patient? Palpate before you place the probe down, and then go back to that rhyme: target, translate, isolate, rotate, interrogate. If you're trying to see deeper structures and there's not great clarity, try using a little bit more pressure and a little bit more gel. And then if you're looking at superficial structures and they're not well visualized, maybe use less pressure but more gel and allow for that sound to be transmitted through the gel. And then there's some specific exams here for cardiac, lung, and abdomen, which we'll go over when we talk about each of those organs. The legal environment of POCUS, the picture I have to represent that here is a picture of the Wild West. And that's because this is very much a Wild West area of medicine, meaning that by and large, there aren't any big guiding organizations or national standards that help to drive home what the standards are for practicing this. We have a lot of people that just bought a butterfly off the internet and they're really excited to use it, but they may not know completely what it is that they're looking at. And that's why we're trying to create such a robust curriculum here, so that you really can go out and be leaders and experts in this field in your local communities, so that they can turn to you while the prevailing consensus seems to be the current legal environment. Now, there are some professional guidelines available with a variety of organizations, and there are some training recommendations that have recently come out, which are consistent with the AIUM, the ACEP, and other guiding bodies. So we hope that you will get at least 150, closer to 300 would be better, precepted scans during your residency. And if you do so in a variety of organ systems and your confidence level is strong and you're passing all of our assessments, then we would say that you are proficient in point of care ultrasound and give you a certificate of proficiency on your final letter when you graduate. This is sort of not specialty specific, so the American College of Emergency Physicians and hospital medicine, those organizations have sort of adopted some of these numbers, but there is no formal, sort of overarching multi-specialty organization that recommends anything other than the AIUM, which is what I go off of. And the other thing to remember is that as this technology grows, expect the legal environment to change, and expect to need to stay in touch with that if you want to continue to use this technology in your practice, which I wholeheartedly recommend. Lastly, billing for POCUS is a sort of controversial topic in many ways because, like I mentioned on the last slide, there's not a lot of regulation, there's not a lot of standards, and we expect this to change over time. As of right now, to be able to bill for POCUS in family medicine, or in any specialty in medicine, quite honestly, first of all, the exam needs to be indicated. You can't just throw a ultrasound on somebody that doesn't have an indication and expect to get paid for doing so. We also need to make sure that these exams are performed by an appropriate provider, but what that appropriateness means, whether it's just local credentialing or privileging, or if they need to have specific training, that's still very ambiguous. You need to specify the type of exam, whether it's a limited or full exam, an initial versus a repeat. That needs to be clearly labeled and sorted out in all of your exams. And you need to be able to report your findings and have stored images that are stored for the long term, meaning you have access to them 5, maybe even 10 years after doing your exam, so that independently people can go back and look to see if they were correct. And lastly, you need to have an interpretation of your findings, which can be documented in your note or on the actual exam as a report. Lots of times in clinics, there are common practice barriers, most commonly being image storage and retrieval, data workflows, meaning how to get those images uploaded into an electronic medical record system, not necessary for billing, but still very much the standard of care. Documentation standards, not knowing that this is something you can bill for, and then some organizations have already implemented internal credentialing or privileging mechanisms and quality assurance mechanisms. So there's a lot of barriers and hoops to jump through, which we are very much still trying to navigate here at Waco Family Medicine, but our hope is that throughout this curriculum, we can give you a little bit of experience with that as well, so that if you go out to your own practice in the future, you'll be able to navigate that environment. And that's the conventions of POCUS. So as a summary, we talked about the patient, the provider, and the machine positioning to optimize our exams. We talked about the different type of probes and the presets that we can use in probe selection to help us image whatever organ system we're looking at. We talked about imaging modalities and B mode and M mode and how we utilize those to interpret different exams. We talked about Doppler and using Doppler to understand velocity. We talked about some of the conventions of orientation and image optimization, and then briefly reviewed the medical, legal, and regulatory landscape of point-of-care ultrasound.